the liver, on the right side, two ducts emerge, which drain the sectors. So the liver, when you look at the segmental anatomy of the liver is divided into multiple segments. Each segment has its own drainage of the bile duct and has its own blood supply. So these segments together form sectors, and these sectors have their own sectoral ducts. So these are the two ducts on the right side, which is right posterior sectoral duct and a right anterior sectoral duct. So these two ducts, right posterior sectoral duct and the right anterior sectoral duct together form the right hepatic duct. On the left side, there is a left medial sectoral duct and a left lateral sectoral duct. So left medial and left lateral sectoral ducts form a left hepatic duct, which is longer and more horizontal. So left hepatic duct is longer and more horizontal compared to right hepatic duct. These two ducts form what is called as confluence. So this is the confluence of the two hepatic ducts, and this right and left hepatic duct together form a common hepatic duct. Now, the length of the common hepatic duct is anywhere from 1 to 4 centimeter, and it is around 4 mm in diameter. This common hepatic duct receives a cystic duct and it forms a common bile duct. So this is cystic duct, and then there is a common bile duct. And the length of the common bile duct is anywhere between 7 to 11 centimeter long. And I told you about the diameter. So 4 years, 40 years, 4 mm, 50 years, 5 mm, 60 years, 6 mm. Anything more than 8 mm is considered to be dilated. And it comes down and it goes beyond the duodenum and comes inferior to duodenum, joins with the pancreatic duct to form the common channel. So this is supraduodenal portion of the common bile duct, and here will be the retroduodenal portion of common bile duct. This is infraduodenal portion of the common bile duct, and some part of it is also intraduodenal, which is intraduodenal portion of the common bile duct. So the right hepatic duct is formed by right posterior sectoral, right anterior sectoral duct. Left hepatic duct is formed by left main sectoral, medial sectoral, and left lateral sectoral duct. These two together form a confluence here. So you cannot call it as confluence also, you can call it as bifurcation also. If you are looking from above downwards, these two ducts are joining. That is why it is a confluence. If you are looking from below upwards, these two ducts are going away from each other. So it is called as bifurcation. So when I use the term 2 centimeter away from the confluence or 2 centimeter within the confluence, or the term 2 centimeter away from bifurcation, 2 centimeter within the bifurcation, it is same. So it is distally. So distally, whether it is 2 centimeter away or 2 centimeter within the bifurcation. So bifurcation and confluence essentially mean the same. Now that receives a cystic duct and forms a CBD. So CBD has the supraduodenal, retroduodenal, infraduodenal, and intraduodenal parts. So what is the blood supply for this? Now, if this is CBD, there are arteries which run laterally around the CBD. And these arteries, they anastomose and they form a fluxus over the surface of the CBD. These are all the multiple small vessels which form a fluxus, and the blood supply, if you take a cross section and you imagine the blood supply is from the 3 o'clock to 9 o'clock position radially. So this is how the blood supply is there. So 3 to 9 o'clock position radially. And then the blood supply is also from superior branches, it is from the inferior branches. Superiorly, the blood supply is from the right hepatic artery and the cystic artery, which is essentially a branch of the right hepatic artery. Inferiorly, the blood supply is from posterior, superior pancreaticoduodenal artery, and which is the last branch of the supramesenteric artery, and gastroduodenal artery. Right. The inferior from below upwards is the 60% of the blood supply, and from above downwards it is 40% of the blood supply. So the proximal ducts are more ischemic compared to that of the distal ducts. That is why more proximal is the injury, the end-to-end anastomosis is not as viable as the injury is more distal. So this is one of the reasons for that. So this is about the blood supply, where there are the CBD is surrounded by two vessels laterally, which form a plexus on the anterior surface. The blood supply is from below to upwards, above to downwards, but major supply is from the below to upwards, which is from the posterior superior pancreaticoduodenal artery and the gastroduodenal artery. From above downwards, it is right hepatic artery and the cystic artery. Sometimes there can be aberrant right hepatic artery, which can originate from a lot of vessels, but most commonly, aberrant right hepatic artery takes origin from the superior mesenteric artery. Sometimes there is aberrant left hepatic artery, which most commonly takes origin from the left gastric artery. So these are the aberrations. So right hepatic artery and left hepatic artery have to originate from the common hepatic artery. But the most common aberration of the right hepatic artery is that it originates from the superior mesenteric artery. And the most common aberration of the left hepatic artery is that it originates from the left gastric artery. Is this clear? Hello.
Yes, sir.
So now after this, we'll go ahead with bile duct stricture. Injuries eventually lead to strictures. So whether you tell bile duct stricture or bile duct injury, it means the same. So what are the causes for this bile duct strictures? See, a stricture occurs whenever there is a injury. Now this injury can be a iatrogenic injury or it can be a traumatic injury. Injury occurs when there is a chronic inflammation. These are all benign strictures, right? There is a malignant strictures is again a separate topic. So the causes for benign stricture is that either there is an injury or there is a chronic inflammation. Now, out of which the most common is iatrogenic injury, and that too during lap cholecystectomy. Injuries in open are less common than in lap because we will have a tactical feedback in open, which is not present in the lap cholecystectomy. It can also occur in surgeries of the liver, hepatectomies. It can also occur in surgeries of CBD exploration. It can occur in surgeries of portal vein procedures. Whatever the structures nearby are present, if you perform any surgery on them, these injuries can occur. So it can because of lap cholecystectomy, hepatectomy, CBD explorations, portal vein surgeries, and hepatocytosis. Trauma very rare, but it can also occur in blunt or penetrating form of the abdomen to the right hypochondria, which is usually rare. Chronic inflammation. So CBD, as I told you, from the liver, it comes all the way and enters into the duodenum, and a little portion of that is intrapancreatic also. So whatever causes inflammation in this area can eventually lead to stricture. So it can be a hepatic abscess, it can be a subhepatic abscess, it can be cholangitis, recurrent cholangitis, or it can be a CBD stone, it can be a chronic duodenal ulcer, which has caused papillary stenosis, which is extending into the suprasphincteric CBD as we discussed in the last class, or it can be chronic pancreatitis, or it can also occur in primary sclerosing cholangitis. So all these are the causes for the benign biliary strictures. Either it is because of the injury, in which iatrogenic is most common, or it is 80% of them are iatrogenic injuries to the CBD. Rest 20% is either because of trauma, which is very rare, or it can be because of chronic inflammation of any structure from the origin of CBD to its end. It can be hepatic abscess, subhepatic abscess, cholangitis, CBD stone, chronic duodenal ulcer, papillary stenosis, chronic pancreatitis, or primary sclerosing cholangitis. Is this clear? Hello. So next we come to classification. Classification of bile duct injuries or stricture mean the same. So initially what Bismuth classified was, if this is a common hepatic duct, right? So according to him, this is the confluence. So an injury which occurred more than 2 centimeter away from the confluence, he called it as class 1. And an injury which occurred within 2 centimeter of the confluence, he called it as class 2. And an injury which occurred at the confluence, but the ducts are not separated. The right and left hepatic ducts are not injured, but yet it is at the confluence. He called it as 3. He called it as 4 when it involved the separation of the ducts at the confluence. And when there was injury to the right sectoral duct, he called it as 5. And 6 was when all the extrahepatic ducts were completely excised, right? Right hepatic, left hepatic, common bile ducts were completely excised. He called it as 6. Right? So 1 is when within 2 centimeter, more than 2 centimeter from the confluence. 2 is within 2 centimeter of the confluence. 3 is at the confluence, but both the ducts are intact. 4 is at the confluence with separation of the ducts. 5 is right sectoral duct injury with common bile duct injury. This is important. It is injury of the right septal duct with the common bile duct. 6 is complete excision of all the ducts. Is this clear? Hello? Hello?
Sir.
So then comes the Stewart classification. So, sorry, then comes, we'll tell this and go to Stewart, Strasberg classification. So what Bismuth did is he identified only the injuries on the CBD and the right sectoral duct. But there are so many other minor ducts which also can get injured. So to include that, what Strasberg did is, so if this is the common hepatic duct, which is going to be a common bile duct, and it is a cystic duct, and there is a liver bed. So once you remove the gallbladder, there is a liver bed or the gallbladder fossa. So what he told is the first injury would be a leak from the cystic stump. So there is either a leak from the cystic stump, or there is a injury from the liver bed. So bile leak from the liver bed, he called it as A. So A is either there is a leak from the cystic stump or there is an injury from the liver bed. Next is if this is right hepatic duct, which is one of the ducts is right posterior sectoral and right anterior sectoral ducts. So right anterior sectoral duct and a right posterior sectoral duct. So this is where there is a injury to this duct, but it has been identified and ligated. So this is occlusion of right sectoral duct, where there has been injury to these ducts and it has been ligated. Now class 3 is where there is an injury to these ducts, but that is not ligated. So injury to the right sectoral duct, but that is not ligated and it is leaking bile. And class 4, what included is there is injury to the main CBD, but it is not associated with any major tissue loss, meaning there is a lateral small injury to this. This we called as D. And in E, he included the Bismuth classification from 1 to 5, right? So that is E1, E2, E3, E4, E5. So this was considered to be gold standard for a very good number of years. So according to Strasberg classification, A is when there is a leak from the cystic stump or there is a leak from the liver bed or the gallbladder fossa. B is the right sectoral ducts have been injured, but they are ligated. C is there is an injury to the right sectoral duct which is not ligated and it is being leaking bile. D is there is an injury to the common bile duct, but it is a lateral injury without any major tissue loss. Then he added Bismuth, where E1 is more than 2 centimeter away from the confluence, less than 2 centimeter away from the confluence, at the confluence, but there is no separation of the ducts, at the confluence with the separation of the ducts, and then there is a right sectoral duct injury associated with the common bile duct injury. 6 he did not include in its classification. Now, this became a gold standard for a good number of years. But this is all based on the pre-laparoscopic era, where the injuries were because of the open surgery, which was very limited. Now, because most of the cholecystectomies are done laparoscopically, most of the bile duct injuries have also become laparoscopical, and the injuries are more common in laparoscopic repair than open repair because most of the procedures are being done laparoscopically. First, second, there is no tactile feedback also. Most important thing is the nature, the mechanism of the injury, and the principles of management in laparoscopic repair or in the laparoscopic surgeries are more different than from the open surgery. So the mechanism of the injury is not in line with the Strasberg classification if it is used. That is why the current classification for the bile duct injuries is based on a laparoscopic injury, which is Stewart Way classification. So the current classification and the management principles are not based on Strasberg Bismarck classification, but rather on the Stewart Way classification, which is much simpler and is in line with the laparoscopic injuries. Now, according to this Stewart Way classification, it has class 1, class 2, class 3, class 4. Class 1 is there is an injury to the common bile duct, but it is a minor injury and it is recognized intraoperatively. Now, this happens when you need to understand the risk factors for each type of the injury also. So the first injury is where there is an injury, lateral injury to the CBD, which is minor, but it is recognized intraoperatively. Now this happens usually when you do lap cholecystectomy. Can anybody tell me how should be the gallbladder traction? Hello, hello, hello. So when you give a traction to the gallbladder, now the gallbladder has to be held at the fundus and it is retracted at the towards the right shoulder of the patient. And you need to apply another forceps here while dissecting the callots and you need to retract it downwards. So the upward retraction of the gallbladder has to be towards the right shoulder of the patient, which is outward superiorly. And at the Hartmann's force or at the infundibulum, the retraction has to be inferiorly and it is outward. So when you do this, the cystic duct forms an angle with the CBD. If not, if you do not give this traction, the gallbladder tends to turn inward and the cystic duct will be in line with the CBD. Now, when this is there, when the angle between the cystic duct and the CBD is acute, it is difficult to differentiate which is the cystic duct, which is CBD. And instead of clipping the cystic duct, the CBD can be clipped. Or instead of dissecting the cystic duct, the CBD can be dissected and it is injured. So if there is no proper traction, then the CBD can be mistaken as a cystic duct and there can be an injury. But this is recognized intraoperatively and there is minor bile leak. Most of the times it is recognized intraoperatively, and there is a bile leak from the CBD, which will tell you that it is a class 1 injury. So this can happen. Or else, if you have done a cholecystectomy properly, but you wanted to get a cholangiogram done, then for cholangiogram to be done, you need to insert the catheter of the cholangiogram into the cystic duct. But for any reason, if you pass it further into the CBD, then there are chances that this can injure the CBD, which is again a minor injury because there can be just a tear. So this injury can happen when the CBD is mistaken for cystic duct or during performing intraoperative cholangiogram when the incision has been extended inadvertently into the CBD. So that is class 1 of Steven. Now class 2 is while operating, if there is a small oozen, a small bleed occurs. Now, while controlling this small bleed, if you apply a electrocautery, this will sometimes cause further bleeding. So you apply that burns, but if you do not hold it properly, more of a normal tissue will be burnt, the vessel wall is burnt, and what started as an oozing starts spurting. Now, when there is spurting, you start to apply multiple clips so as to ensure that hemostasis is secure. Now, in the process of applying multiple clips, there is chance that you can clip the CBD. So, class 2 happens when you clip the CBD inadvertently to secure hemostasis when there is a bleeding. Now, class 3 is you completely transect either CBD or CHD or RHD or LHD. So left, right, common bile duct, any of them are completely transected. This happens when the anatomy is not clear, when you cannot differentiate a cystic duct. Either there's a dilated cystic duct or the CBD, CHD, RHD, LHD are very narrow. So when this happens, instead of clipping and cutting the cystic duct, any of these can be clipped and transected. So there is complete transection of CBD. Now, class 4 occurs when there is a right hepatic duct injury or there is a right sectoral duct. You can see the right sided ducts are always given a special importance, either in Bismuth classification or in Strasbourg classification or in Stewart classification. So, when the right hepatic duct or the right sectoral duct are injured, most often, more than 70% of times, it is associated with a right hepatic artery injury, right? So it is a right hepatic or the right sectoral duct injured with most often injury of the right hepatic artery. Now the vascular injuries are uncommon in class 1, but in class 2 and class 3 and class 4, there is 20, 25 and 70% of chances of injury, right? So class 1 vascular injuries are uncommon. Class 2 may be associated with 20%, class 3 25, and class 4 70%. Right? So this is Stewart way classification, which is considered the standard classification for the laparoscopic injuries. Class 1 is when there is a CBD injury, which is minor and recognized intraoperatively most often. This occurs if there is either retraction is not properly done or if the cholangiogram has been advanced into the CBD inadvertently. Class 2 is when there is lot of bleeding. You keep on applying multiple clips. One of the clip can go and sit onto the CBD. Class 3 is when you mistake the CBD, CHD, RHD, LHD for cystic duct and you completely transect it. Class 4 is when the right hepatic duct or right sectoral duct is involved and most often it is associated with injury to the right hepatic artery. Is this clear? Hello. So now, what are the clinical features? What are the investigations to be done and what are the features of these injuries? So, class 1, along with this, they also added a cystic stump leak. So, these can also be added. So, sometimes there is a leak from the cystic stump. Now, this cystic stump leak occurs when you place a clip onto the cystic stump. Either the clip gets dislodged post-operatively and it starts to leak, or you applied a partial clip. So when you are applying a clip, it is the duty of the camera assistant to turn the telescope to 9 o'clock position and show the complete clip. So when the clip is to be applied, when the other end, the posterior end of the clip is clearly seen, only then it is to be applied. If not, a partial application of the clip will leak the cystic duct, or if the cystic duct has been inflamed, once the inflammation reduces, the stump becomes less edematous. Whatever the clip has been applied, it will distort. So that will produce a cystic stump leak, or it can be a leak from the liver bed. So leak from liver bed or GB fossa, both mean the same. So this happens when you carry out the dissection of the gallbladder deep into the liver parenchyma. Once you separate the cystic duct and cystic artery, it is your job to take the gallbladder out from the liver. So there is a plane, avascular plane. If you miss the plane, you enter onto the gallbladder side, you will injure the gallbladder and you open the gallbladder, which is still okay. But if you enter onto the liver side, if you miss the plane and you go deep into the liver parenchyma, there are a lot of multiple small biliary channels which will get injured. Intraoperatively, you may not see the bile leak, but post-operatively, the patient presents with the biliary leak. Of all the leaks to manage, the most difficult to manage is a leak from the liver bed or GB fossa, and most of these patients will go into sepsis, ARDS, and abscess. So it is the most difficult leak to manage, and HIDA is useful. Of all these leaks, the HIDA scan is useful only in this leak, right? Because there is the bile is just leaking from multiple small biliary radicals from the liver. So HIDA scan is helpful only in this leak. And of all the leaks, it is very difficult to identify this leak and manage this leak. And most of them go into sepsis, ARDS, or the abscess, right? So these two are also included in the Stewart way, but they have not been assigned any class. Now, what will be the clinical features? So if there is a leak from the class 1 leak, where there is a minor leak, it is identified intraoperatively. If it is not identified intraoperatively, and the patient in the post-operative period, the patient will have abdominal distension. This is because of the ileus, and the patient will have pain in the right upper quadrant, and the patient will have either nausea or vomiting. See, all these complications were common. They were considered to be a part of surgery because of extensive bowel handling in a open surgery. But in a laparoscopic surgery, post-operatively, the patient should not complain of abdominal distension or ileus or pain and nausea and vomiting. So if they complain, there can be a injury to this. And you get a ultrasound or a CT done. If you have not placed a drain, then you will see a collection at right hypochondria. So there is a collection. And can anybody tell me, will the proximal biliary radicals be dilated or not? Hello? Hello? Hello?
No,
So the proximal biliary dilatation occurs if there is any distal obstruction. Here, the bile is finding an alternative pathway to go. So that is why there will not be any biliary dilatation. And when you get a blood investigation done, because there is no proper obstruction, the patient will not have clinical evidence of jaundice, although the total bilirubin may be mildly raised. And the ALP, which are both the markers of obstruction, will be mildly raised. So there's only a mild rise in the total bilirubin and ALP. And for all this, the gold standard investigation or investigation of choice is ERCP. When you do an ERCP, the common bile duct will fill completely. The left hepatic duct will also fill completely. The right hepatic duct will fill completely. But there is a biliary leak from somewhere here. So there is a bile leak which is called as biliary fistula. So ERCP will demonstrate a intact biliary tree. There is an intact biliary tree with a fistula, right? So is this clear? Hello. Now coming to class 2. So what happens in class 2? There is clipping of CBD. So once there is clipping of CBD, most of them present post-operative. And because you have completely clipped the CBD, obviously the patients present with obstructive jaundice. And all the features of obstructive jaundice like pruritus, bleeding tendencies, everything will be there. And because there is an obstruction, there is bile stasis, and this bile stasis can get infected, and the patient can also have cholangitis. You get a ultrasound or a CT done. Sometimes these are associated with bile leaks, so you can also get a collection. And what happens to biliary dilatation? Anybody? Hello.
dilated.
So the biliary radicals are dilated because there is an obstruction. And you get a blood investigation done. So obviously the total bilirubin will be raised and ALP is also raised. You do an ERCP. So when you do an ERCP, what happens is there is a filling distally, but then there is an abrupt cutoff, right? So there is an abrupt cutoff because it has been flipped. You can see that there are multiple flips which are present, right? Because you are in a hurry to secure hemostasis, multiple flips are present. So ERCP will demonstrate the cutoff with multiple clips. And before repair of any CBD injury, the most important one of the principles is to delineate the clear anatomy. Now you know that you have clipped the CBD and ERCP will only tell you the anatomy of the CBD till it is clipped. The proximal anatomy you do not know. That is why you should always get a PTC done. It is always the complete biliary anatomy which is the need of the art. So ERCP demonstrates if there is any blockage and ERCP the dye cannot go proximally, you get a proximal PTC done. Right? So this is how they present. Now when it comes to class 3, class 3 is actually unrecognized class 1, right? Because it is complete transaction. So class 3 always presents with the features of class 1 because there is a major bile leak. It also presents with toxicity. And you get a USG or CT done. Obviously, there will be a collection. And there is no biliary radical dilatation because the bile is draining. And you get a blood investigation done. Most important feature will be there is a rise in total leukocyte count because the patient is presenting with toxicity, the CRP is raised, the ESR is raised. And you do an ERCP. In ERCP, you will find that this is where it is distally present, and proximally you have cup applying a clip, right? So there is a truncated proximal duct where it is severed. So there is a truncated proximal duct, and this also needs a PTC. Now, class 4 injury. Can anybody tell me how does class 4 injury present? Hello? Any difference between the class 1, 2, 3 and class 4 injuries? Hello? See here, there is a features of all the class 3 are present, but along with that, the main striking feature is that there is a 70% chance of right hepatic artery injury. So these patients in the post-operative period have hypotension and requiring multiple blood transfusions. Because there is an injury to the right hepatic artery, you clip it, it will lead to the ischemia of the liver. So once there is a ischemia of the liver, they are also present with hepatic abscess. So this is the difference between the class 4 and other injuries where they present with severe hypotension requiring multiple blood transfusions in the post-operative period. And then there is a ischemia of the liver with hepatic abscess. Now you do a ultrasound or this, you see there is a collection. There is no biliary radical dilatation. Here there is no radical dilatation. And you then get a blood done. In the blood, you see that there is fall in the HB, there is fall in the hematocrit. If it is associated with infection, there is rise in the WBC, ESR and CRP will be raised, right? For which again there is no use of ERCP much here. So to delineate the anatomy, you need a PTC is main, but along with that, you need to also get a ERCP done, right? Which will tell that there is a defect either in the right hepatic duct or the right sectoral duct. Is this clear? Hello. Then if there is a cystic duct stump leak, so all these cystic duct stump leak, it again presents with the same features. In ERCP, you can see that there's a leak from the cystic stump. And if it is I already told you about a leak from the bed. So whenever there's a leak from the bed, HIDA is useful here, but still you need to get a PTC done, which is more helpful than ERCP, and these are difficult to manage. So this is about it. Now When do you suspect bile duct injury post-operative? Anybody? Hello. What are the clinical features which tell you that there might be a bile duct injury post-operatively? Hello. Hello.
If patient is developing obstructive jaundice,
Yes. So, if you have placed a drain and you get bile leak in the drain and there is no drain placed, the patient either develops obstructive jaundice if there is a complete obstruction, or else the patient develops abdominal pain, distension due to ileus, fever, features of sepsis, or any patient staying for more than 3 days post lap cholecystectomy. So after lap cholecystectomy, because of some or the other symptom, if the patient has to stay for more than 3 days with any of these features, then you should suspect a bile duct injury post-operative. Now, how do you manage? Management differs intraoperatively and post-operative. Now, if you detect injury intra, the first thing is, if you are able to, if you are confident of repairing, you repair it. If you are not confident of repairing, you place a drain and refer to higher center. If you can repair it laparoscopically, you can repair it. If you are not confident of repairing laparoscopically, you need to do a open repair. Right? Now, if you are confident, you want to repair. How do you repair if intraoperatively you diagnose? The first criteria for intraoperative repair is that if it is not caused by thermal injury. So, if there is an injury which is not caused by electrocautery, because what happens in electrocautery, one electrode is at the site where you are operating and the other electrode is at the limb of the patient. Now the current can pass anywhere from the first electrode to the second electrode, and these electrical injuries, they do not get recognized intraoperatively. They cause delayed necrosis, and that is why what injury you see on the table is, there's like a iceberg phenomena. The injury is much deeper and much wider, and the extent is much larger than what is seen. So that is why the use of electrocautery mandates the further treatment plan. So it is not caused by electrocautery and is recognized intraoperatively and is less than 50% of circumference of duct involved. Then you see if it is a less than 3 mm duct, you can just ligate the duct. There is no problem. You ligate off the duct. If the duct is 3 mm or more than 3 mm, you need to do a repair of the duct over a T2. Right? So if it is less than 3 mm, not caused by electrocautery, less than 50% of the circumference involved. So if this is the smaller duct involved, you can just ligate the duct, it will suffice. But if it is more than 3 mm or at least 3 mm, but it should not be caused by electrocautery and less than 60%, 50% of the duct involved, then you need to repair it. So if this is the injury, you repair it with a non-absorbable suture. place a T-tube, and the end of the T-tube has to be brought through a separate choledochotomy. Meaning, so if you are performing a repair here, do not insert a T-tube here and try to repair over it. Because when you pull out the T-tube, there is a chance that there can be this anastomotic breakdown. So instead, what you do is you repair this and you insert a T-tube through a separate choledochotomy opening, right? So this is the difference between CBD exploration because of a stone and a CBD exploration here. So whenever there is an injury and you want to repair over a T-tube, the T-tube has to be brought out of the CBD through a separate incision and not through the incision of the anastomosis. Okay. For any chance, either it is injury is caused by electrocautery or it is involving more than 50% of circumference. Any injury caused by electrocautery or involving more than 50% of the circumference, you need to resect the duct. So you need to resect the injured area. And when you resect the injured area, you see the distance between the proximal and the distal end is less than 1 centimeter. So the defect is less than 1 centimeter and it is more than 2 centimeter away from the confluence. Then you can do a end-to-end anastomosis with a T-tube, trans-anastomotic T-tube. So the distance is less than 1 centimeter and the injury has occurred more than 2 centimeter away from the confluence. You can do a place a T-tube over here and do a end-to-end anastomosis. But if either the defect is more than 1 centimeter or it is within 2 centimeter of the confluence, you need to do a hepaticojejunostomy, where the proximal end you insert into the jejunum and the distal end you close it off. That is called as oversealing. All right. So this is intraoperatively. So intraoperatively, what it tells is if it is not caused by electrocautery, less than 50% of the circumference of the duct involved, less than 3 mm duct, ligate the duct, at least 3 mm or more than 3 mm, repair over a T-tube, and the T-tube has to be brought out to a separate choledochotomy incision. If it is either caused by electrocautery or if it is more than 50% of the circumference involved, you resect the injured area. And after you resect, the distance between the two ends is less than 1 centimeter and it is 2 centimeter away from the confluence, you do a end-to-end anastomosis over a T-tube. But either one of this is positive, either it is more than 1 centimeter defect, or if it is occurring within 2 centimeter of the confluence, you need to go ahead with a hepaticojejunostomy, which is obviously a Roux-en-Y hepaticojejunostomy. Is this clear? Hello? Hello? Hello?
Yes, sir.
But what the modern guidelines tell is when you do a end-to-end anastomosis of a CBD, there are more chances of ischemia because, as I told you, the blood supply is from the 3 o'clock position to 9 o'clock position. When you need to mobilize the ducts, these all small vessels get lacerated, they get severed, and they get fibrosed and they get stenosed. That is why, even if you do an anastomosis, either the anastomosis fails because of ischemia or there is a high chance of stenosis of the anastomosis post-operatively. So that is why what they tell is, irrespective of its distance from the CBD, it is better to go ahead with a hepaticojejunostomy. So always hepaticojejunostomy, whenever possible, is better than a end-to-end anastomosis of the CBD. So based on this, if there is a class 1 injury, what do you want to do? Hello. Intraoperatively, you saw that there is a class 1 injury. What do you want to do? Hello. So there is a minor injury to the lateral border of the CBD where you can repair over a T2. If there's a class 2, obviously it is recognized post-operatively. A class 3 injury is complete transection, so obviously Roux-en-Y hepatocystinostomy is needed. A class 4 injury, you refer, put a drain and refer to higher center. Right? This is based on Stewart classification of intraoperative injuries. Now, post-operatively, you did not recognize it, so you recognized it post-operatively. So, post-operatively, you have a clinical suspicion of bile duct injury of all those factors, right? The patient developing abdominal pain, abdominal distension, ileus, or there's a bile. So, what is the first step you need to do? Anybody? Hello? 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 So, when there's a clinical suspicion of a bile duct injury post-operatively, the first step that you need to do is to stabilize the patient. Do not take the patient for OT immediately. So you stabilize the patient. And then once you stabilize the patient, you investigate the patient. So the first investigation would be either you get an ultrasound done or you get a CECT done. So when you get either an ultrasound or a CECT, that will show you the collection. So when there is a collection, you aspirate it if there is no drain, right? So you aspirate it. And if the aspiration shows that there is a bile, you need to drain the bile. So the second step would be to drain biliary ascites. Because preoperative drainage of biliary ascites is one of the most important factors in long term, affecting the long term outcome of the biliary repair. So you drain biliary ascites. Then there is inflammation. So the third step would be to control infection. Because you do not control infection, infection leads to inflammation. And when there is an inflammation, there is an increased rate of stricture formation. So you control the infection. Once you control the infection, the fourth step is to delineate anatomy. And the investigation of choice to delineate anatomy is ERCP. But anywhere, if the ERCP is not delineating the complete anatomy, you need to add a PTC, right? If it is a proximal duct injury or there's a transaction or there's a complete blockage, if the ERCP cannot delineate the entire anatomy of the biliary tree, you need to add a PTC. So this is the principles of management. The first step is to stabilize the patient. Then you get an investigation done, ultrasound or CECT, where there's a collection, you aspirate. If it shows bile, you drain the biliary ascites by putting a percutaneous catheter. Then you control the infection and then you delineate the anatomy. You take the patient for surgery only after delineating anatomy, after all these four steps are done. So this is very important. Without controlling infection, without draining biliary ascites, without delineating the anatomy, you take the patient for surgery, the patient will have either incomplete repair or there is a recurrence of the injury or there is recurrence of stenosis of it. Now, when it comes to pillars of surgery, post-operative management, there are three important factors. One is pre-op cholangiogram. So you need to delineate the anatomy by pre-op cholangiogram, which is by ERCP with or without PTC. The second most important thing is the surgical technique. Surgical technique is the most common surgery for a post-operative biliary stricture is hepaticojejunostomy. So when you do a hepaticojejunostomy, for any anastomosis, it has to be a tension-free. Second, you do it with a single layer anastomosis. And third is pre-op biliary drainage. has to be achieved. Right. Fourth is the tissues have to be debrided properly, and then use a absorbable suture. Right. So these are the principles of surgical technique. So you need to achieve pre or biliary drainage first, and when you recognize the injury, you debride it till the normal duct length is achieved, and you do a tension-free anastomosis, which requires adequate mobilization of the duodenum. And the anastomosis of a single layer is better than a double-layered anastomosis, and using a absorbable suture is much appreciated. The third is surgical experience. Whenever possible, refer to a higher center, because lot of studies tell that when the repair is done by a center where commonly CBD repairs are being done, that is much more better than the centers where the surgeries are rarely done. So the three most important principles is you need to get a pre-op cholangiogram done and the surgical techniques and refer to a center which is experienced. Now, after this, when you post him for surgery, him or her for surgery, so post-op stricture or injury, you post them for surgery. So first is you give a incision. The incision can be a right subcostal incision, which is called Kocher's incision, or you can extend as a hockey stick maneuver into the midline, right? So it can be a right subcostal incision, or you can also extend it. Once you extend the incision, you enter into the peritoneum, you release all the adhesions which are present. Once you release the adhesions, you identify and dissect CBD, a common hepatic duct, right hepatic duct, left hepatic duct, and the sectoral ducts. All of them have to be identified properly, right? You start by incising the peritoneum over the left hepatic duct, and you can continue the same plane to dissect the right hepatic duct and also the CBD and CHP. Once you identify them, you loop the structure and you recognize the injury. So you see where exactly is the problem, because pre-operatively you got a cholangiogram, then you know exactly where is the problem. Confirm it intraoperatively, and intraoperatively when you confirm it, if there is a CBD stricture, the CBD is intact, but there is a stricture, you resect the stricture, and the proximal end. When you resect stricture, this is how you get a stricture. So when you resect the stricture, the distal end you close it off, and to the proximal end you attach a loop of the jejunum, which is essentially Roux-en-Y hepatico-jejunostomy. So you, whenever there's a stricture, you resect the stricture and you do a Roux-en-Y hepatico-jejunostomy if it is more than 2 centimeter away from the confluence. But there is no stricture, there is complete transection. Then again the answer is same. You debride the proximal duct till it becomes normal. You oversee the distal duct and you attach a loop to it. This is again essentially Roux-en-Y hepatico-jejunostomy. So if it is more than 2 centimeter away, the answer is you do a Roux-en-Y hepatico-jejunostomy. Now, if it is close to the confluence or which has extended into either the right or left hepatic duct, there is a separation of the right and left hepatic duct. So, what class would it come under Bismuth classification if it has caused separation or hello? Hello? If it is extending to confluence but has not separated, what class would
Yeah,
it come?
class 3.
So class 3 is it has extended into the confluence but has not separated. So in class 3, now it is going up to the confluence, right? The confluence is involved. Now in this case, what you need to do is Because as I told you, the left hepatic duct is horizontal and it is longer, you can mobilize it. The distal end, anyhow, you will close it off. In the proximal end, you can close the right hepatic duct and you give an incision over the left hepatic duct. You can extend it onto the right hepatic duct and you do a side-to-side hepaticojejunostomy, right? Because it has involved the confluence and the left hepatic duct is longer, you can mobilize the left hepatic duct, give an incision onto the left hepatic duct, you extend it onto the right hepatic duct, and you do a right side to side hepaticojejunostomy so that the bile from the right hepatic duct will enter the left hepatic duct and it drains into the jejunum. So this is called as Bloom-Gart modification of hep side to side hepaticojejunostomy. This was end to side. This is the end of the common bile duct, and you attached the jejunum to the side. So this was end to side Roux-en-Y hepaticojejunostomy. But here, this end you closed, and the end of the jejunum you closed. You did a side to side anastomosis. So this is Bloom-Gart modification of hep side to side hepaticojejunostomy that you do when there is a injury at the confluence, but they are still intact. For any reason, if there is an injury to the confluence and both of them get separated, so there is separation of the right hepatic duct and there is separation of the left hepatic duct, then what you need to do is you need to do a separate hepaticojejunostomy. So this becomes right hepatic duct and jejunum anastomosis. This is left hepatic duct and jejunal anastomosis. So if it has involved these ducts, you need a separate. These two have to be implanted into the jejunum separately. Now, for any reason, this has gone into the right sectoral duct or right hepatic duct. Now, if this is an injury to the right hepatic duct, this has happened, but this is the left hepatic duct. Left hepatic duct is fine. So you let the left hepatic duct to be in continuation with the common bile duct, which will enter into the duodenum and drain into the duodenum. But you take another loop of the jejunum and you close the distal end of the right hepatic duct, you implant this right hepatic duct into the jejunum, right? So if the right sectoral duct or the right hepatic duct has been injured, do not attempt its re-anastomosis. Do not do the re-anastomosis of the right hepatic duct or the anastomosis of right hepatic duct to CBD. So take the injured segment, proximal segment of the right hepatic duct and let it drain into the jejunum by doing a Roux-en-Y hepaticojejunostomy on the right duct, so that the right duct will drain into the jejunum directly, while the left duct through the CBD drains into the CBD. Right? It drains into the duodenum. So this is how you manage post-operatively. So post-operatively, you do a laparotomy. Post-operatively, if you recognize, after doing all those four important steps, you open the patient, you clear all the adhesions, then you see if there is any stricture or injury more than 2 centimeter away, it is clear-cut hepaticojejunostomy. If it is less than 2 centimeter away, but not so close to the confluence, we can still go ahead with a hepaticojejunostomy. But if it is involving the confluence, but yet the two ducts are not separated, then you can do a Bloom-Gart modification of hep side to side hepaticojejunostomy, where the side of the jejunum is anastomosed to the side of the left hepatic duct. But if the two ducts are separated, you need to implant them independently into the hepatico-jejunal segment. So this is independent hepatico-jejunostomy. For any reason, if the right sectoral duct or the right hepatic duct have been injured, then you need to implant that duct into the loop of the jejunum and do not try to anastomose it with the remnant of the duct or with the CBD. Is this clear? Hello.
Yes, sir.
Now, how do you do this hepatico-jejunostomy? Right. So, how to perform this hepatico-jejunostomy? Till that part, the CBD part is clear, right? You need to always debride the proximal duct and keep this ready. So the proximal duct is ready to be implanted into the hepaticojejunostomy, into the loop of the jejunum. The distal duct you have oversieved, right? Closing of this duct is called as oversieving. So you take a suture and you oversew the distal duct. So the proximal duct is now ready. To achieve a tension-free repair for any hepaticobiliary surgeries, the Porcher's maneuver is very important. So where you incise the peritoneum on the lateral aspect of the duodenum so that the duodenum, the pancreas get lifted off from the retroperitoneum. So for any surgery of the hepatobiliary pancreatic diseases, Porcher's maneuver is a must so as to achieve a tension-free anastomosis. Then you need to take the loop of the jejunum, right? So to take the loop of the jejunum, if this is the DJ flexion, where the duodenum stops and the jejunum ends, from there, 30 centimeter from there, you apply a stapler. Right? So you stop this. You apply a stapler and you divide it. Right? So this has to be at least 30 centimeter from the DJ junction. And then you can use this loop as a rule loop. So this is the jejunum which is present below this. You take this loop and you bring up to here. You close this end so that this can be utilized for the end to side. So this is end, this is side, right? So you close the end of the proximal end of this loop and you utilize it for end to side anastomosis. Now, this will drain the bile through here, but the food will still keep coming through here. You need to maintain the continuity. So, to maintain continuity, what you do is, so if this is the duodenum, this is the proximal part. Now, this was the distal part which you took to the CBD. Then this part will be remaining here. Now, you take this and you anastomose it, right? So, this will become a side to side jejunostomy. This will become a end-to-side hepaticojejunostomy. Now, this limb is called as rule limb, and the rule limb has to be at least 40 centimeter, right? So, it has to be at least 40 centimeter. Now, food will come through here, and the bile will come through here. Both of them mix here, and they together go to the ileum. So, this is how a Ru and by hepaticojejunostomy is done. So you need to transact the jejunum 30 centimeter distal to the DJ junction, take the limb, close the proximal end, make a end to side anastomosis at the hepaticojejunostomy preferred site with the proximal duct, and 40 centimeter has to be the minimal length of the limb, right? And when you suture, if this is the proximal end and this is the jejunum which is ready for it to be sutured. The jejunum has an anterior and posterior. What you need to do is you need to take the sutures anteriorly first. So you take these anterior sutures, multiple sutures are taken anteriorly, and all of them are held with a stick. And then you take posterior sutures between the wall of the jejunum and the duct, and then you tie the posterior sutures first so that this will be lifted here, and then you tie the anterior sutures, right? So you take the posterior anterior sutures first, keep straight, and you then take the posterior sutures, but you tie the posterior sutures first and then you tie the anterior sutures so that it forms a end to side hepaticojejunostomy. Is this clear? Hello. So the last part is there any role of dilatation? So for example, if there is a stricture here, what you can do is you can pass a guide wire through the stricture, and then you put a balloon and you inflate the balloon. So this inflated balloon will cause the opening up of the CBD, dilatation of the CBD will happen. So this is called as balloon dilatation. If stricture has formed, you can have a balloon dilatation. You can use balloons from 4 mm to 10 mm. After you dilate, you need to place a stent, and this stent has to be replaced every third month. And then you can remove the stent after 1 year. So this is also one method where if stricture has already formed, you can just dilate it. Now, if it is a distal stricture, you do a balloon dilatation by ERCP. If it is a proximal stricture, you do a balloon dilatation for a by PTC. Now, when they made a graph of this, they found that the success rate for surgeries till 5 years and for the balloon dilatation, they are almost the same till 5 years. But after 5 years, the success rate for the surgery, they kept maintaining the graph, but the success rate for the balloon dilatation fell rapidly. So, till 5 years, there is no difference whether you do a surgery or a dilatation. But after 5 years, the balloon dilatation usually fails, and there is a need for repeat surgery. And most of these patients with CBD injury are patients of cholecystectomy, which is in the middle age group, 30 to 40 years of age group. They still have a long life to go, and 5 years is a very short duration in their long life. That is why always surgery is preferred for over balloon dilatation. But if you have performed a good repair with an experienced surgeon and there is a restenosis, now in such indications, balloon dilatation can be considered. So the only indication, good indication for balloon dilatation is already CBD repair has been done, but in the due course you have developed a stenosis. Instead of going a second resection of the stricture and repeat surgery, a balloon dilatation would be better. Right? So this is about a